to adrenaline. Today's topic of discussion is disorders of heme synthesis, mainly porphyrias. Porphyrias are a group of disease associated with the hereditary and acquired deficiencies in the biosynthetic pathway of heme. It includes the increased production and excretion of porphyrins or their precursors. Now about the classification. Mainly, there are three types of classification of porphyrias. They are congenital or acquired, hepatic, erythropoietic or both according to the site of overproduction of porphyrins. Now mainly acute and chronic. We are going to look at the acute and chronic classification of porphyrias. Now among the acute porphyria, there are three types of porphyria. They are acute intermittent porphyria, hereditary coproporphyria, variegate porphyria, and among the chronic porphyria, there is congenital erythropoietic porphyria, hereditary protoporphyria, mixed type porphyria or cutaneous tarda. We are mainly among these porphyria, important one is the acute intermittent porphyria. Now, all porphyrias are autosomal dominant except congenital erythropoietic porphyria, which is automatic recessive. When the mutation of DNA happen, there is abnormalities in the abnormalities of enzymes of heme synthesis, which leads to accumulation of ALA and PBG, aminolevulanic acid and PBG, and there is porphyrinogen accumulation in skin and tissues. And both these leads to different processes. On the accumulation of ALA and PBG, there occurs neuropsychiatric signs and symptoms. And when there is porphyrinogen accumulation, there is oxidation of this porphyrinogen to porphyrin and causes photosensitivity. This causes the difference in clinical manifestation on the different enzymes deficiencies. Now about the types of porphyrias in detail. This is a table showing the method of heme synthesis and when what disease is caused by the deficiency of certain enzymes. Now let's look into detail about the ALA synthase deficiency. It is due to potential lethality. There is no known defect of ALAS1. Defect in ALAS2 causes anemia, not porphyria. It leads to sideroblastic anemia and not porphyria. PLP dependent X-linked sideroblastic anemia is the ALA synthase deficiency. It is not that much important. ALA's non-erythroid type is inhibited by heme. Porphyrinogenic drugs deplete heme. This decreases the feedback inhibition on ALAS. This causes the increase in synthesis of intermediaries of heme. Neurological symptoms are seen more in the ALA synthase deficiency. Now about the diagnosis. Demonstration of mutation in erythroid ALAS gene is the diagnosis of ALA synthase deficiency. Now about ALA dehydratase deficiency. It is autosomal recessive called PBG synthase deficiency also. Features similar to acute intermittent porphyria, abdominal pain and neuropathy. There is increased plasma ALA, increased urine ALA and coproporphyrin 3. Decreased ALAD in erythrocyte is also seen in ALA dehydratase deficiency. ALAD deficiency is extremely rare. Now about the differential diagnosis, the lead poisoning or tyrosinemia type 1 may occur as ALA dehydratase deficiency. Now about the main topic, which is the acute intermittent porphyria. Acute intermittent porphyria is an autosomal dominant disease. Now the PBG deaminase is deficient in acute intermittent porphyria, that is UPG1 synthase deficiency. There is secondary increase in the activity of ALA synthase since end product inhibition is not effective in acute intermittent porphyria. Now about the acute intermittent porphyria, the ALA and PBG levels are elevated in blood and urine. As you know, the glycine plus succinyl-CoA gives, in the presence of ALA synthase gives aminolevulanic acid, which on the action of ALA dehydratase causes porphobilinogen or PBG, and which in the presence of PBG deaminase causes a formation of HMB. And here PBG deaminase is deficient. The fresh sample of urine is colorless. On standing, urine becomes red in color due to the oxidation of porphobilinogen to porphobilin. Hence, urine samples for PBG estimation should be collected freshly and transported in dark bottles. Now about the clinical features of acute intermittent porphyria. Symptoms appear intermittently and they mimic other disease. Hence, it is also called little imitator. And the features are acute abdominal pain, neuropsychiatric disturbances, and there is no photosensitivity as no porphyrins are found here. Women have less severe manifestation before menarche and after menopause. Thus, female sex hormones have a stimulatory effect on ALA synthase. Drugs like barbiturates are known to induce ALA synthase and can precipitate an attack. Attack is also precipitated by alcohol, starvation and stress. And the third point, that is the drugs like barbiturates induce ALA synthase, is important here. Symptoms can be relieved by a high carbohydrate diet or IV glucose drip. Many of the precipitating factors induce hepatic cytochromes, thus heme is depleted further. The negative feedback on ALAC is lost, and this causes the overproduction of porphyrin and precipitate acute intermittent porphyria. This is about the acute intermittent porphyria, which is very important among these topics. Now about the congenital erythropoietic porphyria. It is an autosomal recessive type. Here, UPG3 cos-inverse enzyme is deficient. It is also called Gunther's disease. The 4-PBG is converted to linear tetrabarrel, that is hydroxymethylbilane, which is converted to UPG3 by UPG3 cos-inverse. But in congenital erythropoietic porphyria, the UPG3 cos-inverse enzyme is deficient, thus leading the formation of UPG1 and spontaneously CPG1, which are useless compound formed in excess, and this causes photosensitivity. Hence, there is overproduction of UPG1 and CPG1, which causes autooxidation of these give uroporphyrin 1 and coproporphyrin 1. Normally, type 3 isomers are produced, but here type 1 is produced in excess. Type 1 isomer lead to ineffective feedback inhibition, further increasing the way. The 4-PBG is converted to linear tetrabarrel, that is hydroxymethylbilane, which is converted to UPG3 by UPG3 cos-inverse. But in congenital erythropoietic porphyria, the UPG3 cos-inverse enzyme is deficient, thus leading the formation of UPG1 and spontaneously CPG1, which are useless compound formed in excess, and this causes photosensitivity. Hence, there is overproduction of UPG1 and CPG1, which causes autooxidation of these give uroporphyrin 1 and coproporphyrin 1. Normally, type 3 isomers are produced, but here type 1 is produced in excess. Type 1 isomer lead to ineffective feedback inhibition, further increasing the